Hello, I'm Trudie Lobban, and I'm the founder of Arrhythmia Alliance, STARS, and the AF Association, three charities putting the patients first, but working in collaboration with healthcare professionals, patients, caregivers, policymakers, all those affected by or impacted by heart rhythm disorders. And I established the Heart Rhythm Congress in 2005, which brings together all these individuals and groups to one meeting, and it's now become the largest heart rhythm meeting in the UK.
Thank you. My name's Shouvik Haldar. I'm a consultant cardiologist and electrophysiologist at the Royal Brompton and Harefield Hospitals. I have a significant interest in medical education and research in all arrhythmia related areas. And it was really nice to be approached by Trudie Lobban and Professor John Cam now probably 5 years ago in 2020 to consider being HRC Programme Director. So I took that role on, and I think we've done, fabulous work building on the previous sort of 15 years or so of work, basically making HRC Congress a real must event in the arrhythmia calendar. I think it brings together so many different people in the cardiology workforce, in the arrhythmia arena, and it's just been fantastic to work in that capacity. So that's where I fit in.
So our 21st Congress has just happened at the ICC in Birmingham, and what a long way we've come. Back in 2005, it was held at the Motorcycle Museum, and I was told that maybe we would attract 150 delegates. We had 850 then. This year, 21 years later, we have between 500-600 delegates per day. So, around about 2,000 if we include the patients over 3 days. And we moved from the Motorcycle Museum to a hotel, and then we outgrew that. And now, year on year, it's held at the International Conference Centre. And what's fantastic, it brings together the arrhythmia community in the UK, from primary care, nurses, physiologists, cardiologists, electrophysiologists, policymakers, primary care, and also some neurologists, which is great. And but it also attracts an international delegation. And this year was exceptional. We had the president from Heart Rhythm Society in the US, the largest heart rhythm society in the world. We had the president and president-elect from ERA, the European Heart Rhythm Association, which is part of the European Society of Cardiology. We had the president from the World Society of Arrhythmias, and we had many, many other international experts from around the globe, and some that return year after year after year, and others that were new this year. Canada, America, across Europe, Australia, Africa. We had a gentleman fly in from Ghana just to be at the meeting and to meet us, wanting to see how it's done, how he can set up a service in Ghana, in Accra, the capital, to start offering devices, pacemakers to the community there. And we're very, very pleased that we'll be able to help him through our Pace for Life programme. But he heard about us through Heart Rhythm Congress. So it truly is an international meeting, attracting the great and the good and those wanting to learn and expand. And importantly, and it's unique to any other meeting in the world, is the Patient Day, which is held on the Sunday. And we have patients and caregivers talking, but importantly also hearing from medical experts and able to ask them questions directly. So I'm really proud of what we have and the support that we get from well-known organisations, as well as our own president from the British Cardiovascular Society. And I think Shouvik would agree that it's pretty unique that a patient organisation, although we're a little bit more than that, but primarily we're a patient organisation, can deliver such an event. Shouvik.
I completely agree, Trudie. I mean, I think the fact that, firstly, I think the numbers were up again. since COVID, each year incrementally increasing numbers. It just goes to show the community that has developed. And I think that's the strength of this meeting. It's the whole spectrum of people involved, from patients to clinicians to all our allied health professional support staff, nurses, physiologists, everybody is involved and increasingly getting involved, which is so good. I think HRC provides a platform for showcasing the work that they do, whether it's research, whether it's quality improvement projects, patient pathways, all of those things are allowed to be showcased and are showcased. And the patient element is kind of the icing on the cake. I think having patient participation really validates the whole purpose of HRC in the umbrella of Arrhythmia Alliance. I think just the additional thing to say is that, not only have we got all of those people who come and present and are part of the Congress, but the international faculty that come willingly, often asked to come to this Congress, shows the reach of this organization and this meeting, which I think is unique compared to anywhere else in the world. So really pleased to be part of this, and I think it's going to continue to evolve and grow in the next few years as well.
Shouvik mentioned about, unique, having the patients there. This year, we held a session on patient and public involvement in research to make clinicians aware of how much we can contribute to their research. Arrhythmia Alliance, STARS and AF Association are involved, and me personally, in so many research projects, but we can offer surveys out to patients, out to clinicians, a database of over 130,000 patients, over 40,000 healthcare professionals. So we can help recruit, we can review, we can gather evidence for research. So it really is bringing everybody together, and the ethos of Arrhythmia Alliance is collaboration, and no better place than to see that in action other than Heart Rhythm Congress. So as patients become better informed, which is what we want, and we say patients, but really it's people living with the condition. Nobody wants to be a patient. And if you're a patient, you want to get better. But sometimes you just have to accept that you have to live with something. So we tend to now say people living with, whether that's the person that's been diagnosed with the condition or their family, their loved ones, their colleagues at work, wherever, they're living with this condition. So we want to inform them. We want them to be educated on what they should and shouldn't do and how they can best manage the condition they're living with. But by doing that, we all know Dr. Google exists. And so often, sadly, inaccurate information can be gleaned from the internet. What we want to do is make sure, which is what I've done since day one back in 1993, is ensure that any information, any education we provide is accurate and approved by medical experts, whether that's through our resources, our website, our e-news, our patient day, whatever we do. Then as patients become better informed and better educated, they also want to ensure that they're accessing the best treatment and management for them. And that can vary. Several patients can have one condition, but treatment for one may be very different than treatment from another. So we educate the patient, we learn and educate from the healthcare professionals and from industry who are developing new devices, new drugs, etc. But what we have to ensure is that services, the NHS, can deliver the latest innovations and treatments. And so, as well as having a patient day, as well as having medical events such as Heart Rhythm Congress or Heart Rhythm Updates or others that we organise, like the European Pacing Summit, etc., we need to also educate the patient and identify where there are gaps in delivery of treatments, which we're currently doing through STARS and the lack of syncope services in the UK and in fact across Europe. And we will also be looking at ablation services. Ablation is being recommended for those that are suitable as a first-line treatment for AF, which is fantastic. However, if your primary care physician doesn't know about ablation, then you're not going to be referred. Or if there isn't a service in your area, you're not going to access it. So we need to make sure on an advocacy side, on a policy side, that demand and supply, I guess, exists so that people can access the best services for that individual. And part of doing that is having patient days, educating the patient. So we had a huge session on ablation and the different types of ablation, which is really a #1 topic at the moment because NICE approved pulse field ablation not so long ago. So there are 4 or 5 types of ablation available now. Not everyone is suitable for any of them, and some are only suitable for certain types. So we've now developed discussion guides. Hospitals are ordering these discussion guides for their patients, and the individuals are downloading or ordering them from us so that they understand and they can ask informed questions with their clinician, or they can say to their GP, I've heard about this, can you refer me to an expert so that I can discuss it with them to see whether I might be suitable. And so it's giving an all-round education. It's not just one Sunday in October that we educate patients, or 3 days in October that we educate clinicians. It needs to be year-round and in lots of different ways, and then bringing it all together at Heart Rhythm Congress.
Thank you. So I've had a long-standing interest in medical education. So that was my kind of first pull into the Heart Rhythm Congress, and being offered the opportunity to be program director really allows you to shape the agenda, the sessions, and I think the thing that was really good about it is the education element, not only for doctors talking to doctors, but also encompassing the whole workforce. That's really important because we don't work just as sole physicians anymore. It's a wider team. There are nurses, there are physiologists, there are so many different cardiology workforce members that are involved in the care of an arrhythmia patient. And we've really tried to bring that into the Heart Rhythm Congress in terms of education. So not only do we do sessions for doctors in terms of just standard didactic education, but we showcase their work, their research, their future plans, but we're also doing the same for our additional cardiology workforce. So nurses, physiologists being the key example. In recent years, I think one of the highlights have been that we've introduced sessions where we're supporting the career and guidance of those particular specialists, which I think they find invaluable because they don't find that information easily elsewhere. So as we develop and nurture our wider workforce, you're getting much more better educated workforce, which then translates into better informed patients and better care. And I want to pick up on what Trudie just said before about patient education, because as a clinician, you know that fear, anxiety in terms of patients is due to lack of understanding or education about their condition. So the more that HRC and Arrhythmia Alliance do in this arena, the better our patients are and the better they can manage their condition, seek out care if they don't have the appropriate, let's say, facilities in their region. And to another point is that there is a lot of regional disparity in availability of treatment. So empowering patients to understand what's out there can really drive services to be developed where there are lack of infrastructure or facilities. So all those areas, I think, really makes HRC quite unique. And I think all of those areas makes me interested to continue to develop with Trudie and her team, because it's such a great body of work and the collaborative spirit is amazing. And so you want to come back for more each year.
So Arrhythmia Alliance was established in 2004 when STARS, I was just running STARS at that time, Syncope Trust, worked with others to bring about policy change and introduction of a new chapter to the National Service Framework on Coronary Heart Disease. And we were successful, and that was launched in March 2005 by the Department of Health on arrhythmias and sudden cardiac death. Originally, the 7 chapters were launched in the year 2000, and arrhythmia was mentioned once, and atrial fibrillation wasn't mentioned at all. So we managed to get atrial fibrillation into chapter 8, as we call it. However, there was still very little. I mean, people were being told, oh, it's just something you get when you're older and you've got to live with it. I mean, it's incredible in such a short time. We've gone from, that's just an old person's disease, it's no big deal, to knowing so much. I think round about that time, there were just a few hundred research papers published, whereas now there's, I think it's over 10,000, if not more, published articles and research on atrial fibrillation. So Arrhythmia Alliance was founded to raise awareness of syncope, loss of consciousness, which often is a symptom of underlying fatal arrhythmias leading to sudden cardiac death, and also the lack of services for heart rhythm patients in the UK. There were only 30 arrhythmia nurses and 60 electrophysiologists, heart rhythm cardiologists. We now have a few hundred nurses and in excess of 300 electrophysiologists. So that's the difference. Having done that, so we began to realize that atrial fibrillation wasn't just a little problem for old people. It was a major problem, generally older people, but also young people, some even in their 20s. But irrespective of age, it was something that could be treated. The major thing was atrial AF-related stroke. People used to talk about prevention of stroke in AF, which didn't mean anything. If you went to your doctor and your heart was racing and you were lightheaded, felt like you had a bag of worms in your chest, being told prevention of stroke, they would then phone us and say, I went about my heart, but it's talking about my brain. So we changed that around to AF-related stroke, and how AF can cause a clot in your heart, which can break away. It can cause heart failure, but it can also travel to your brain and cause an AF-related stroke. That one simple change of description saw an increase in adherence to anticoagulation therapy medication, because then people understood why they were be giving anticoagulants, whereas before it didn't make them feel any better. Many stopped taking it. So that led to a reduction in AF-related strokes and new anticoagulants. Before that, there was only one anticoagulant that had been on the market for 60 years that had many, many side effects. For some, it was fine. For others, they just could not tolerate it. 2007, 8, 9, 10 saw the introduction. They were called NOACs, they're now called DOACs. There were 4, I think, brought to market almost within 2-3 years of each other, with fewer side effects. Don't need to have regular blood tests, which was something else that put people off, and a huge reduction in the number of AF-related strokes. Coupled with, I say, new devices, new drugs to actually treat atrial fibrillation, suddenly there was an explosion of solutions to AF, but there were still a lot of people undetected. So in 2011, we launched the Know Your Pulse to Know Your Heart Rhythm It Could Save Your Life campaign with simple pulse checks. And this army of people in contact, over 51% of our inquiries to atrial fibrillation, more than 51% were related to atrial fibrillation. So in 2007, we launched the AF Association, because if you're diagnosed with something, you Google that diagnosis. You wouldn't Google arrhythmia because you've been told it's atrial fibrillation. And so demand and supply, basically, the good old economics, demand and supply. There was a demand for information, there was demand for treatments, and suddenly there was a supply because anticoagulants could reduce AF-related stroke, and a supply of new treatments, new devices to better manage the condition. I think, you know, that says it all. We still have a long way to go. In those days, it was about 500,000 people thought to have AF, then it crept up to 750, 800. It's now 1.62 million, the latest number in the UK, with approximately another 450,000 yet to be diagnosed. So we're talking of over 2 million people plus with atrial fibrillation. It is the most common heart rhythm disorder.
I think globally, atrial fibrillation has absolutely rocketed in terms of prevalence. So I think the latest numbers that I've read are way more than 60 million cases globally. And that's increased at least 3 to 4-fold in the last decade itself. So this is a huge problem. As we know, people are living longer. But with that, there are associated health conditions that people are living with. So there is sort of increasing sedentary lifestyles, more obesity. With that, hypertension, so high blood pressure and diabetes, and all these things contribute or co-sort of exist with atrial fibrillation. Now, the thing about detection is that there are many patients who are highly symptomatic with atrial fibrillation, but there is a very large proportion of patients who are minimally symptomatic or have no symptoms. So they don't really know how they've got it. And that percentage could be as high as 30 to 40%. Sometimes some publications say even higher than that. So you can imagine you've got that huge number of patients potentially with it, but a huge number of people who don't know they have it. So the number could actually be much higher. And as Trudie's mentioned previously, one of the bad things about atrial fibrillation is stroke. A stroke can be life-changing, completely devastating to quality of life. And actually, if you have an AF-related stroke compared to a sort of normal stroke, let's say, it's much more devastating in terms of its impact to one's life. So there's been a lot of move about how do we try and diagnose patients and screen them better to detect atrial fibrillation. And there are many different technologies out there. You can do so quite easily nowadays, potentially with portable handheld devices or longer ambulatory ECG monitors. There are many different ways, but still we are not reaching all the people that need to be diagnosed. There are some concerns about screening because, as you know, if you screen, you are likely to potentially get some people who are misdiagnosed or incorrectly diagnosed, and there is some anxiety about what happens in those scenarios. But I think overall, the move is tending towards focusing on those at risk. So, for example, those at 65 and over who may have a risk factor. If we focus on those people where prevalence is much higher of AF and where the risks of the stroke, the heart failure, the hospitalization is greatest, if we can identify those people with a variety of different techniques, that's where the community is heading. And I think the Arrhythmia Alliance is instrumental in doing so many pieces of work to make this awareness greater for patients.
Yeah, well, we launched a simple Know Your Pulse, the 3 fingers on your wrist to get to know your heart rhythm. More or less at the same time, so AliveCor Kardia was coming to market. It was the first of its kind, and it was so easy, 2 fingers onto the little device, and that could give you a 1-lead ECG, EKG to be able to detect AF. So we worked with AliveCor Kardia and Dr. Dave Albert, because at that time you were building algorithms to be able to launch it and get it approved by NICE and the FDA. And I know Dave Albert is on record saying AliveCor wouldn't be where you are today without the support of Arrhythmia Alliance, because the gentleman that headed up AliveCor in the UK, I knew from previous work that we had done. And he said, we really need to get patients using these. And I said, well, I can do that. And he said, how many do you need? 50, 100? I said, well, a few hundred. So he brought them to HRC. We offered them to patients on Patients' Day on the understanding that they would use them once a day for 3 months. That's all they had to do. That was many years ago. Some are still using them and have updated them. And we realized how simple, how easy it was for the public to use. So we started using them at our Know Your Pulse events. And that definitely helped, because then they had an ECG that we could email to them, that they could take along to their doctor and show, look, doctor, especially for those with paroxysmal AF, where it comes and goes, they'd go to their doctor, they might not be in AF at that time. Whereas for the first time ever, they had medical evidence. So Cardia became, and still remains, very much part of our Know Your Pulse campaign, whether it's using 3 fingers or using a NICE approved device that can confirm, which you can use to share with your doctor. Even doctors will hand these out now as well. And during COVID, obviously everything stopped until vaccine stations opened up, and came up with the idea of, well, we could do Know Your Pulse again. A couple of people that I said that to thought I'd totally lost it, but I hadn't, because when you were sitting down for one of the vaccines, you had to sit and wait for 15 minutes afterwards. But whatever you did, they were sanitizing everything as you came in, as you sat down, as you left. So it'd be so easy to sanitize just a small little cardia. So we made some videos, again, thank goodness to online recording, videos, posters, and many, many COVID centres agreed to host Know Your Pulse. So people, they either, as the injection was being, the vaccine was being prepared, they could do their 2 fingers, etc., or it was over on a station. And again, people that were wiping down the chairs, wiping down the desk, etc., just wiped over the AliveCor. And so people could continue to be detected for AF even during a pandemic in lockdown.
Hugely. I mean, I think we used to rely on very sort of short ambulatory Holter monitors, usually sort of 24 hours. And obviously you would miss episodes of intermittent arrhythmia, atrial fibrillation with such short duration monitors. Now we've got loads of choices. So we've got extended patch monitors, but the handheld ECG devices or wearables have been, I think, transformative, because we can diagnose arrhythmias when the patient also chooses to detect. So what you get then is direct symptom rhythm correlation, which is really important, because if a patient feels something, can record it on their handheld device and can bring that to you, you know that they've only recorded it when they felt something. You can then directly say, okay, well, this is something, not something, or something like atrial fibrillation. And if you can get that direct confirmation, then you know that what you'll be treating is going to help them or impact them. Because there are a number of things that you can get which may be coincidental. We all have certain arrhythmias short-lived. If we put monitors on ourselves all the time, we'd find lots of stuff that we not necessarily would mean that we have symptoms with. So it's that direct correlation which is transformative. And in my practice, I can say that the advent of wearables and handheld devices has reduced, I think, the time to diagnosis, number one, and then the time to any relevant intervention. And that is huge. Whereas, in the past, you'd have to wait for a doctor-initiated test, which could take weeks. You may then have to wait for the result, which may take weeks or months. And then again, what the decision is in terms of the intervention. You can appreciate that could be several months, even up to a year, that whole pathway. But if you've got something where the patient can help, can bring their data along to you, you shorten that whole time frame significantly.
Ethos of Arrhythmia Alliance is collaboration. Our doors are always open to collaborate with everyone, every group, every organisation, with a purpose to improve outcomes for people living with heart rhythm disorders. That isn't just direct to patient, that is by improving services, by improving training and education for healthcare professionals so that they can deliver the best options to the people living with the condition, so it improves their lives. But I cannot stress enough that we are always open to collaboration. That is the whole point that I established Arrhythmia Alliance. There were many meetings around the country in the UK being held, and everyone was saying there were too many meetings, can't go to all of them. Industry was saying this is ridiculous, it's costing too much. And that's when I came up with the idea, well, what about having one meeting in a central place and anyone can host a meeting within that? And that was the conception of HRC, and that still stands. And that's what's so good. As well as our agenda, other organisations have meetings at HRC, whether it's part of the agenda or whether it's a side meeting, so that we're not taking clinicians away from their clinics and making waiting lists in the NHS even longer. We are giving an opportunity, a platform to bring the whole community together, to exchange, to educate, and to work. And my vision is for that to only get stronger and to work with others. No one person or one organisation can do everything, but together we can achieve so much more.
I think HRC is here to stay. I think that's for sure. I think the collaborative spirit that Trudie mentions is the key, sort of bringing together everyone from patients to clinicians, workforce and industry is the real strength. And the next generation of healthcare professionals are going to be managing arrhythmias probably in very different ways than we are doing now, given that this space is so technologically rich and advancing at such a quick pace. And I think we don't even know how it's going to develop, the management, and therefore the platform that we are developing and continue to nurture is the key thing that we're going to leave for the future generations, because that platform gives the workforce and the wider community the opportunity to bring fresh ideas to the table, to test out research, to discuss with patients things that are going to be ways we treat patients that are going to be innovative in the future. So my plan is to continue to develop the educational program, the platform, to allow the future generations to be able to treat arrhythmias in the best possible way for our patients. It's an interesting question, because I think, you know, the demands of working life are getting quite significant. And I think, you know, people are being much more conscious of, I guess, work-life balance. So becoming involved in societies, institutions is getting a little bit more difficult in terms of sort of time available to do stuff. But I think if you make the offering attractive, give them a platform where they can really bring their work, their research, their ideas to be able to be showcased, tested, provide them visibility. I think it's the opportunity that HRC and AA provide that is going to be the real strength, to allow clinicians to use this platform and bring their work to future generations and to patients. So I think we just need to continue developing that. And that's what we do each year. And if we keep on that track, then we should continue to nurture the future generation of cardiology arrhythmia specialists.